So as we all know that optic nerve evaluation is central to the glaucoma diagnosis and management. So I'll be talking about the 10 steps of ONH evaluation. So a normal optic disc has a very high inter-individual variability, and a dilated examination is very, very important for a stereoscopic view. So first step is the size. It can be small, medium or large, which is less than 1.5, 1.5 to 2 or more than 2. How do we measure the size? So with a slit lamp beam, we measure the vertical and horizontal diameter, and which is inside the scleral rim. Do not include the scleral ring, and we multiply it with the correction factor, which is mostly 1.3 for a 90D lens. And second thing which we need to keep in mind is to compare both the discs for the right as well as the left, because sometimes the size is different, so we can see the cup disc ratio is also different, and there can be a discrepancy in the CD ratio. Second is the shape. Usually the disc is vertically oval, and sometimes it can be torted, which is rotated more than 15 degrees from the vertical meridian, or it can be tilted, which is three-dimensional angulation of the anterior-posterior optic cup axis. And these things are usually associated with astigmatism and amblyopia. So what is the clinical implication is that if in a very young kid, if we see a disc which is of a tilted, torted shape, and so we need to rule out any refractive error and prevent amblyopia. Third is neuroretinal rim size. We all know ISNT rule, inferior rim is more than superior, more than and then nasal, then temporal, and any change in the ISNT rule will point towards glaucoma. So in glaucoma, first the inferotemporal and then the superiotemporal rims are affected, and followed by temporal horizontal, nasal inferior and nasal superior. And the cause is that in inferior and superior parts, the lamina has larger pores and thinner connective tissue, which can lead to more damage to these parts of the nerve. Secondly, these nerve fibers are also thicker, and also hypothesis is that the distance from the central retinal vein vessel trunk exit from the lamina cribrosa plays a role. So more far the area of the disc from the central retinal vein trunk exit, more is the damage. So a notch is a circumferential extent of less than or equal to 60 degrees, which is 2 contiguous clock hours, and it is associated with RNFL defects many a times. There can be generalized rim thinning or a progressive rim thinning, as we can see in the pictures. Coming to the NRR pallor, if pallor is more than cupping, it points towards non-glaucomatous neuropathy or a acute rise in pressure, like we can see in acute angle closure attack or in a JOAG patient, or traumatic glaucoma. So in this picture we can see that pallor is more than cupping, which points towards non-glaucomatous optic neuropathy. Coming to the step 5, which is CD ratio. Configuration and depth of cup are best judged by stereoscopic examination, and what we need to follow is the optic nerve blood vessel, which kinks once they climb up the cup wall, and then they will kink again when at the cup rim junction. So the second kink is the one we need to see, and that will determine the cup disc ratio. So in this picture you can see that it is climbing up, and this is the second kink, and this is what we will see, and not the color of the disc. Also a high cup disc ratio can be seen in large disc, which may lead to overdiagnosis of glaucoma, and low cup disc ratio can be seen in small optic nerve heads, which can lead to underdiagnosis of glaucoma. Coming to the configuration and depth of optic cup, deepest optic cups can be found in glaucomatous eyes with high minimal values of IOP, such as juvenile onset angle glaucoma and secondary open angle glaucoma, like traumatic recession and anterior chamber angle. And shallow can be seen highly myopic eyes, as we can see in this picture. Coming to the peripapillary atrophy, alpha zone is mostly present in almost all of the patients, which is irregular hypo or hyperpigmentation and thinning of the chorioretinal tissue layer. And beta zone is mostly associated with glaucomatous eyes, where there is marked atrophy of RP and choriocapillaries with good visibility of choroidal blood vessels and the sclera. If the beta papillary zone is present in the poles or at the area where we suspect that there is thinning, it is highly suspicious of glaucoma, and also glaucoma is associated with enlargement of peripapillary atrophy. Step 8 is examining the retinal nerve fiber layer, which is best done in red-free light. We need to notice the striations, brightness and visibility of parapapillary retinal vessels and look for any diffuse or localized RNFL loss. It can be seen as dark over light. You can see the dark area over the light surface. So, bright and fine striations are mostly visible in inferotemporal and superotemporal sectors because they have the maximum retinal nerve fibers and they decrease with age. Localized defects can be seen as seen in the picture, which are less than 60 degrees. They are mostly associated with a notch or a parapapillary atrophy. This is the diffuse RNFL loss. You can see decreased, increased visibility of the retinal vessel border and diffuse loss of striate patterns. Coming to the disc hemorrhage, it can be splinter or flame shaped, mostly found in 4 to 7% of eyes with glaucoma, very rarely found in the normal eyes, and it again is associated with a notch, and once it resolves in 2 to 3 months, it will lead to a RNFL defect. So a patient with disc hemorrhage needs to be followed up frequently. So we will call the patient again after 3 months to assess. And then comes the last step, vascular signs like bearing of circumlinear vessels, bayoneting sign or arterial narrowing in glaucoma, which is found again near the part of thinning. These are a few examples where you can see a notch is associated with the superior. So again, if in investigation we find any defect, then we need to clinically correlate it, and that's why a disc evaluation is important. So again, to conclude, evaluation of optic nerve is central to diagnosis and management of early glaucoma, and it differentiates it from non-glaucomatous atrophy. Dilated examination is the most important, and also examination of RNFL along with ONH is important for early diagnosis of glaucoma. Thank you so much.